Today we will speak something about clinical science of respiratory system. On clinical examinations, many signs are there which students have some doubts. So I want to clarify that first. First, I will talk about the percussion of the clavicle. So percussion of the clavicle, how you do? It is the medial 1/3 of the clavicle. So this is the clavicle. This is the clavicle from sternal end to the acromial end. So you divide into three parts. Medial 1/3 is the area on which you percuss, because the apex of the lung lies beneath this portion of the clavicle. So do like that. Is that direct percussion? So you do like this. You can. I am doing little stretching of the skin. I am doing so that the percussion will be proper. This especially you should do for the people who are little obese and old people, where the skin is very lax. Number 2, examination. That is chronic isthmus. So you have an area of resonance because of the apex of the lung. It is extending from front to the back. That is the isthmus. The medial portion is bound by the dullness of the neck muscles, laterally by the shoulder muscles, dullness. So this is the strip of area resonance which has to be seen in the patients. That is because of the apex of the lung which lies there. So put your finger here like this. So muscles are here, neck muscles, shoulder muscles. In between you put the finger and then percuss and find out the resonance. Okay. Trial sign we do. So here you fix the patient's head. Okay. And then you use the 4 fingers. 2 fingers, one is the ring finger and the thumb. You put on the sternal end of the clavicle on either side, like this. And then put the 2 fingers, that is the index finger and the middle finger, on either side of the trachea. On either side of the trachea, and then trace it down. So when you are tracing down, you are putting your finger in between trachea and the sternocleidomastoid. So in this gap, you are able to feel the resistance between the trachea and the sternocleidomastoid. And as you come down, what happens? If the trachea is in the center, the resistance will be equal on both the sides. If it is shifted to one side, whichever side the trachea is shifted, you get the more resistance. Okay. I like to explain to you the mechanism of the sternocleidomastoid clavicular head becoming prominent when the trachea is deviated. So before knowing this, we shall know that the trachea is enclosed with the deep cervical fascia as pretracheal fascia, and it surrounds the sternocleidomastoid muscle also, trachea also. So when the trachea is shifted to one side, the deep cervical fascia becomes relaxed. The function of the fascia is to keep the structures beneath it in place. When it is relaxed, the structures deep to the fascia tries to pop out. So this is what happens to the sternocleidomastoid muscle. That's why the muscle becomes prominent when trachea is deviated to one side. Now we speak about the measurement of diameters of the chest. We have anterior AP diameter and the lateral diameter. Okay. For that you take 2 long books like this. Hardboard is still better. For the time being, I am taking the 2 books which is quite stiff. It has to be stiff. And the patient, and these books are kept like this on either side of the patient. Equally, sir. So, ಜಾಸ್ತಿ ಅಮಕ್ ಬಿಡಿ. ಸುಮ್ಮನೆ ಇಟ್ಕೊಳ್ಳೋದು ಅಷ್ಟೇ. Now you see the two books are parallel. That is more important. When you feel that it is parallelly placed, then you take the measurement. ಸ್ವಲ್ಪ ಇದು ಹಿಂದೆ ಹೋಗ್ಬೇಕು, ಅಲ್ಲಲ್ಲ ಇದು ಸ್ಟ್ರೈಟ್ ಆಗಿ ಹಿಂಗಿರ್ಬೇಕು, ಆ ತರ ಇಟ್ಕೋಬೇಕು ನೀವು. ಹಂಗೆ ಇಲ್ಲಿ ಒತ್ತಿ. So when it is parallel, you take the measurement, lateral measurement. You can take like this, the inner aspect of the book. You see that the books are parallel, and then take the measurement. Okay. Now comes the AP diameter. AP diameter you take like this. Sir, one ಕೈ ಇಲ್ಲಿ ಇಟ್ಕೊಳ್ಳಿ, ಇಲ್ಲ ಇದು ಬಿಟ್ಕೊಳ್ಳಿ, ಆ ಕೈ ಹಿಂದ್ಗಡೆ ಬರಲಿ, ಈ ಕೈ ಹಿಂದ್ಗಡೆ, ಈ ಬುಕ್ ಇಟ್ಕೋಬೇಕು ನೀವು. ಓಕೆ, ಅರ್ಥ ಆಯ್ತಾ? So this two books are kept, one in the front, one in the back, and also see that the books are parallelly placed, and then you take the measurement. Take the measurement. This is the AP diameter of the chest. Now we speak about the ratio, AP diameter and the lateral diameter ratio, how to calculate. After taking the measurements of AP and lateral view, you put the AP diameter, whatever value you got, in the numerator, and transverse diameter in the denominator, and take the fraction. Usually, normally it is 0.71. 0.71 is the normal ratio. And when emphysema is there, that is the barrel-shaped chest, both becomes equal, then it becomes 1. So 0.71 will become 1. That is what we call as emphysematous. Chest is emphysematous. So this is the ratio. Whatever value we get, you do the fraction and find out whether it is normal or abnormal. Now we speak about the movement of the chest, how it moves. As we were taught in the physiology, the upper portion of the chest, which moves up and down, that is what we call as pump handle movement. Lower third of the chest moves bucket handle. So for the bucket handle, how do? You keep your hand like this, and the thumb you look into how the thumb moves. Tawali sir, usro? Bidi? Tawali? Okay. So the upper portion of the chest and the lower portion of the chest, we can do pump handle and the bucket handle type of movements, which you can do from the front as well as from the back, by standing in the front as well as in the back. Now comes the middle portion of the chest. In the front, we can keep the hands like this and ask the patient to take the breath. Tawali sir, usro? Usur tawali bidi? Usur tagon bidi? So you can see to and fro movement of the hand, and you can compare left and right, and on the back side, and in the back side, the way you are doing for the lower part, same way you do, and see the movement of the thumb, and when you are keeping the thumb like this, and see for the difference. Tawali sir, usro? Tawali? Bidi? Tawali? Bidi? So these are all some of the simple tests which students feel difficulty in knowing. So I am trying to demonstrate it. Thank you.